Hi, my name is Haley. I'm going to tell you about our patient. Her name is Lily. She's a 4-year-old Caucasian female that's been experiencing right ear pain for about 1 week. The patient's father reports some improvement with Tylenol and ibuprofen every 6 hours. He states that her pain is impacting her ability to sleep and that she's been less content than usual. Lily states that the pain never goes away. She rates the pain a 6 out of 10 with the FACES pain scale in the clinic. The patient's father states that she had an ear infection in the past. He guesses about 2 since birth that required treatment with antibiotic therapy and resulted in improvement. Lily and her father deny recent fevers, congestion, cough, or other cold and flu-like symptoms. They deny drainage, tinnitus, hearing changes, and contact with sick persons in the last 2 weeks. Lily does attend preschool 3 to 4 days per week. Lily has no other pertinent medical history related to today's visit and does not take any medications. The differential diagnoses for this patient include otitis media with effusion, or OME. Fluid in the middle ear does not have acute inflammation or symptoms with a fever or pain. The eardrum normally isn't bulging, but it may appear gray or amber in color. Another one would be otitis externa. That's where the ear canal becomes painful, inflamed, and swollen, and this typically involves a small portion of the auricle. The tympanic membrane typically appears normal with otitis externa. And then lastly, bullous meningitis. It's an infection condition where blisters or vesicles develop in the tympanic membrane. This infection is limited to the tympanic membrane and generally very painful. The cause of this is unknown, but typically it's said to be viral. The primary diagnosis for this patient ended up being acute serous otitis media on the right. This diagnosis was confirmed via otoscope examination. The key features present in Lily's case that led to the diagnosis were a bulging tympanic membrane, erythema, and partial opacification of the membrane. Lily also was increasingly fussy and had pain with the infection. AOM, or acute serous otitis media, is caused by eustachian tube dysfunction, where middle ear fluid becomes trapped. This allows the pathogens from the nasopharynx to reproduce and leads to inflammation, purulent effusion, and a bulging tympanic membrane. Lily really has no cultural or spiritual beliefs that impacted health and illness. Social determinants of health screening was negative. The patient's family has adequate resources and denies financial concerns. There's no concerns related to health literacy, economic instability, or safety. Lily is a preschooler with no known secondhand smoke exposure, alcohol or drug exposure in the home, or domestic violence. So Lily should be started on an antibiotic since she has completed the 48 to 72 hour watchful waiting period without antibiotics. So she should start amoxicillin 9 ml liquid orally twice a day for 7 days. This treatment plan was chosen because, according to Gattinara et al., amoxicillin or Augmentin should be chosen as first-line antibiotic options for 7 to 10 days after that watchful waiting period has completed. Considering Lily was experiencing right ear pain for over a week, it's safe to initiate antibiotic therapy within current antibiotic therapy guidelines for AOM. Twice a day in comparison to 3 times a day is no less effective, so that would be a good option for her, and the dosage was calculated based upon her weight in kilograms. Here are the resources that I used to cite throughout my PowerPoint. If you have any questions, please let me know.